Moving on, let's complete the case study on comfort and sedation in critical care. The PDF is located at the bottom of the LMS as well for you to work along on paper. In this patient scenario, we have Mr. Jonathan Wright. He is 62 years old with a past medical history of chronic obstructive pulmonary disease, COPD, hypertension, and chronic pain due to degenerative joint disease. His current status: Mr. Wright was admitted to the ICU with an acute exacerbation of his COPD, requiring intubation and mechanical ventilation. He exhibits signs of agitation, including tachycardia, hypertension, and resistance to mechanical ventilation. The healthcare team is initiating the ABCDEF bundle that we discussed previously in previous chapter. We want to use this to manage his symptoms while ensuring his comfort and safety. Let's go ahead and take 15 minutes and work out these case study questions, and then at the 15-minute mark of this video, we'll again go through the answers together. That's the 5 minute mark. And that is the 10 minute mark. So 5 more minutes and we'll go over the answers. All right, 2 more minutes and we'll go over the answers. All right, for part one, the first question: what are common causes of pain, agitation, and delirium in critically ill patients like Mr. Wright? The answers include causes like an inability to communicate, invasive procedures, monitoring devices, pre existing conditions, and the ICU environment itself, full of lots of light and noise. For question two, how can the Richmond Agitation Sedation Scale and the Critical Care Pain Observation Tool be used to assess Mr. Wright's condition? The RAS assesses levels of agitation and sedation to guide the sedation management, while the CPOT evaluates nonverbal indicators of pain, such as facial expressions and body movements. And for question three, what are the potential risks of inadequate pain and agitation management in this patient? The risks include increased morbidity and mortality, delayed ventilator weanings, hemodynamic instability, and long term physiologic effects such as PTSD. All right, in part two, discussing that ABCDEF bundle, just as we discussed in our lecture, that ABCDEF bundle, it's a systematic approach to managing pain, agitation, and delirium, and prioritizes early mobility and family involvement. What will be prioritized for Mr. Wright in this? That'd be the pain management and sedation. And that'd help address his agitation and discomfort, along with regular delirium assessments to prevent further complications. And for that family engagement and managing his symptoms, family engagement is going to help provide that emotional support, help identify patient needs, and promote adherence to the care plan. For part three in our pharmacological management, why is fentanyl an appropriate choice for Mr. Wright's pain management? Fentanyl has a rapid onset, it's easily titrated, and causes minimal hemodynamic effects, making it ideal for critically ill patients. What advantages does dexmedetomidine offer compared to benzodiazepines? Dexmedetomidine provides sedation without respiratory depression, facilitates communication, and may reduce the incidence of delirium. And for three, what nursing interventions are necessary to monitor for potential side effects of these medications? Again, those interventions include vital signs, assessing his sedation levels using the RAS, checking signs of respiratory depression, and evaluating for hemodynamic changes. For our quiz question, the nurse is preparing to assess Mr. Wright's sedation level. What tool should be used? Would that be A, the behavioral pain scale, B, the confusion assessment method for ICU, the CAM-ICU, C, the Richmond Agitation Sedation Scale, or D, the numeric rating scale? And that answer here is going to be C, the RAS, or the Richmond Agitation Sedation Scale. And finally, for part four, In addition to pharmacological interventions, the team incorporates non-pharmacological strategies such as music therapy and family interaction to reduce his agitation and delirium. For our first question, what non-pharmacological interventions should be used to complement Mr. Wright's care? Again, those interventions include music therapy, guided imagery, promoting sleep hygiene, minimizing noise and light, and involving the family for reassurance. For question 2, how can the ICU environment be adjusted to minimize factors contributing to delirium? Those adjustments include reducing noise, providing natural light, and ensuring consistent day-night cycles and limiting unnecessary stimuli. And finally, for our final question, number 3, why is it important to balance sedation and mobility in critically ill patients? Balancing sedation and mobility prevents complications such as muscle atrophy, venous thromboembolism, and prolonged ICU stays. Anyway, that's all we got for this case study.